Another violated his early back in June, was admitted here in July, was discharged in August. Substance treatment, apparently didn't stay there. Substance treatment, he started sipping it. Now it's coming here. No legal documentation since his stuff in June.
On 16? Oh, really? Okay. Oh, cool. Thank you, sir.
I'm used to it.
Yeah, that's
I think it's going to be like I said, the outside.
I happy to put that in my documentations and protections. The income use that. That'd be amazing.
So it'll work.
We're actually streaming now. He's at 2, so research, benefits.
Okay, I guess we'll get started. All right. You know me, I'm not Mr. Formal Intro, because people will read like a list of accolades. It's a distinct privilege to introduce him all. He's a professor emeritus at the university. The thing that struck me about him is some of you guys have stereotypical images, like nerdy research professor, right? Crazy psychiatrist, right? So that's kind of my template was before I met Dr. Paul. And the thing that struck me about him was several things. One, great goatee. Second, all right, really nice, right? Super nice, down-to-earth guy. And the third thing was he really had a passion for teaching and for medical students, you know? Like he got involved back when no one really was beating the door, I think, for that job, you know?
No, they were running the other direction.
But then he would like switch and start talking about his rats and these experiments, and I like, oh yeah, there's the scientist guy, all right? Okay. So he's done a lot of research. He's done a lot of teaching. He's going to talk to us today. It's really a privilege to have him. You know, I think you're going to really enjoy his style. He's a solid person, and that's really not as common as we wish, right? So thank you so much for coming. We're really lucky to have you.
Thank you so much, Dr. Martin. Appreciate it. Do you need me to mic up, or can I leave it?
It's up to you, right?
If it's up to
It would help
if it'll help, I'll put it on. Okay. Well, first of all, I'll give you a translation of what Professor Emeritus means. Professor Emeritus means I get to say no. All right, goes in my pocket. All right. So what I'm going to talk to you about today is something that I have been wanting to get involved in for years, and that's the Asylum Hill Project. And unfortunately, I simply haven't had the time. As Dr. Norton was saying, at one point, I used to refer to myself as the captain of the leakiest ship in His Majesty's Navy. And each morning I woke up and wondered, do I bail today or caulk? Which is going to keep the ship afloat longer. So when I retired, I fortuitously ran into Lyda, well, she was Gibson, now she's Lyda Kay. And she mentioned that they now had access to legal access to the case files prior to 1936. So prior to the asylum moving here, all of those case files are open. The problem is they had nobody to read them. And one thing about me is that in addition to the other things that interest me, one of my passions over the years has been medical and psychiatric and mental health history. So I know a lot about early terminology and how to translate it into modern terms. But let me give you a little background here. First off, I want to thank Dr. Ralph Didlake, who heads up the Asylum Hill Consortium, and he generously gave me the first roughly third of this presentation to give you a little background to the Asylum Hill project. Dr. Jennifer Mack, who's the bioarchaeologist heading the excavation. Lyda Kay, who is kind of the do-all and be-all manager. And then, of course, the Asylum Hill Consortium for the access to the case files prior to 1936. So let's start with what is the Asylum Hill Project? All right, you all, I assume, know about the University of Mississippi Medical Center. And what you see today is this sprawling campus covering, I believe the figure is pretty close to, pretty ballpark, 200 acres of land. And it was established in 1955 as one hospital and school, and that was it. And it's expanded pretty much exponentially over the years. Prior to the medical center was the Mississippi State Lunatic Asylum. And the reason the medical center is located where it is because that land has been historically owned by the state of Mississippi since prior to 1855. So the asylum stood there until from 1855 to 1935. The area went into decay for 20 years, and then the medical center was built on top of that, which I consider poetic. For years, I used to cheerfully say that my office sat on top of the Mississippi State Lunatic Asylum, and I felt it was very appropriate. Now, this asylum went through an enormous number of changes. It was formed in the antebellum period. It saw the Civil War, Reconstruction, Jim Crow, things like the influenza pandemic of 1918. I even have some case files of people suffering from encephalitis lethargica, which Dr. Norton knows about, was a neurological sequelae to the influenza pandemic that looks an awful lot like Parkinson's disease. The Great Flood of 1927, those of you who are not Mississippi natives may not know about it, but in 1927 there was a massive flood of the Mississippi River beginning north of Memphis and running all the way down to New Orleans. It flooded pretty much all of the Delta region of the state of Mississippi, as well as a lot of the region south of that. The Great Depression, and one of the things the asylum saw a lot of was the evolution of medical practice. Now, one thing I want to begin by disabusing you of. The asylum started out as a state-of-the-art facility. It was considered one of the premier state mental hospitals in the nation. And And what I can tell you from my research is that even in the 1920s and 30s, they were doing their best to try to stay ahead of current technique. Now, this is the asylum in its full form in 1925. And you can see the original You can see the original building here, the African American wards that were added later, and additional buildings such as the infirmary, et cetera. But what I want you to notice, especially those of you that are familiar with the medical center, is look where it's located. It runs right up to the corner where Old Canton Road splits off from North State Street. In fact, it sits where the medical center sits, and that's going to become important in just a moment. Now, this is what the medical center looked like when it first appeared. And you can see it's just this modest structure, big for the time, but modest by modern standards. And what I want you to do is try to envision in your mind how this lines up with that. So basically, everything that is the medical center sits on top of what used to be the asylum and its grounds. And in fact, the medical center itself is located almost exactly smack on top of where the original asylum building was built. Now, one of the things that happens with expansion, especially with a limited space, is at some point you start to run out of room. The medical center, I started at the medical center in 1993. I'd say it began to run out of room a couple of years before I arrived. Now, in 2011, a routine road improvement, not very far from what is now the dental school, came upon an unmarked grave. And ultimately, they found 66 unmarked graves that were exhumed between between 2012 and 2013. Now, in 2014, they began this archaeological survey. Why did they do that? Well, because for those of you who are familiar with the campus, the last remaining undeveloped land on UMC campus lay between University Drive as it runs into Lakeland and St. Dominic's. That whole area, nice wooded area, I used to go on picnics there. Turns out it contained a few graves. In fact, whoops, come on, what did I just do? There we go. So, in fact, what they began to determine was that there were between 4,000 and 7,000 burials. What do you do about that? We're no longer in the era where the solution is, as it would have been probably when the medical center was first built, to simply pave over the graves. So what became a problem was, how do we deal with this? What are the administrative, ethical, financial, you name it. It came with a host of problems. What do we do about 4,000 to 7,000 graves? Well, what we did, because of this guy, Ralph Didlake, is formed the Asylum Hill Research Consortium. And this brought together archaeologists, historians, psychiatrists, neurobiologists like myself, or I don't know what I really fit. with the goal of respectfully exhuming the bodies, or what remained of them, researching to the extent that that was possible, and then reinterring the graves somewhere else. The guiding principles are respectful management of the remains, continuity of care. You may think that's an odd thing to say about remains that are upwards of 90+ years old, but we take very seriously the fact that these people are still our patients, okay? And we treat them that way. We try to honor as much as is possible each individual person. We make a great effort to engage the descendant community, acknowledge the cultural importance, but also maximize the research and educational value while exercising stewardship. And that has involved an enormous collaboration among all sorts of academic, governmental, and non-governmental partners. So the project consists of exhumation, curation, memorialization. It's, so there's an enormous effort to try to identify the remains, which ain't easy, because as Jennifer explained to me, Yazoo clay isn't just destructive to buildings, it's destructive to everything, including bodies and bones. Research, that's where people like me come in, and education, okay? Education, Jennifer has a team of bioarchaeology students from, I believe, Southern and Mississippi State that come there every summer and sweat their tails off all summer doing the hard work, and it is hard, of exhumation. Ultimately, we want to catalog everything, create databases, create research protocols, you name it. All the things that are needed to get a project like this going in an ethical, responsible, and academically useful way. Phase 2 was to get funding for all of this. This is not cheap, as you can see. We needed to develop a team, exhume burial sites, that's in process, curate the remains, also in process. A field school has been established. We're working to engage descendants, expanding databases and collections, that's part of my job, and ultimately repurpose the land for future UMC project. Yes, John?
If they hadn't done that road and found that grave,
They'd never have
there was no historical record of them?
Nope. We knew, if you go into the files, you will see, particularly in the case reports, that there was a hospital cemetery, but the location isn't specified. And if you remember that insurance map from 1925, the map doesn't indicate any cemetery, even though it was there. And in fact, at that time, there would have been extant markers. Problem, of course, is that very few of the markers were in stone. They were almost all wood. Wood doesn't do well anywhere. Wood does even worse down here. Ultimately, we want to create a permanent memorial and mausoleum, creating an interdisciplinary study of history, remains, and artifacts, returning remains to families where possible, and ultimately creating a long-term, ongoing project to both help our project, but also projects around the country, because this is not the only place where this is happening. All right, so let's get to my part of the deal. What I'm going to present to you is a preliminary analysis of case files. I anticipate that I'll be working on this project at least until 2028. And I'll explain, you'll see why in just a minute. Now, there are an enormous raft of documents in the Asylum Hill project. In fact, give you a little tidbit. Younger son, James, did his honors thesis for the Barksdale College on the asylum using part of these state records, long before I got involved. In fact, I think before even the Asylum Hill, well, the Asylum Hill project was underway, but it was still at a very small level. Anyway, what I'm working with is this set of records right now. 414 PDFs, about 2,500 pages each. They're available to me on a secure drive, and we'll talk a little bit more about what I'm doing with them. Ultimately, I need to get to these records, which are even larger, the paper files, and again, I'll explain why in just a minute. Now, my data set is 415 scanned files, 414, 415, depends on who's counting. What's notable is that these files all come from the Mississippi State Hospital infirmary archives. Each PDF is about, by my count, is about 2,700 pages. Each one has about 100 case files. As I mentioned, recent Mississippi state legislation permits me to examine the files of patients admitted before 1936. Whoops. In consultation with Dr. Didlake, he and I interpret this to mean that I can analyze a file from any patient admitted prior to 1936 for as long as they were at the state hospital. So while many of my patients die or are discharged before 1936, I have quite a number of cases that I am able to follow up to the 1950s and 1960s. Now, out of those 100 case files, typically, I can legally and ethically examine between 20 and 40 cases. Other files are from patients who were admitted after 1935, and those are off limits. The earliest files date from about 1880. That's about as far back as this set goes. My latest records date to about 1965. What I'm going to talk to you about today, I was hoping to get the first 100 PDFs, but I just didn't quite make it. So it's 93 and about 1,900 cases. Now, last thing to mention, the information available to me ranges from one cover page to hundreds of pages. It just depends on when the patient was admitted and how long they stayed at the asylum. This is a good record prior to 1920. This is what I'll get. Name, I'm lucky here, they actually gave this one a case number. Most of them don't have that. Where they came from, their name, when they were admitted, age, race and sex, domestic situation, form of mental disorder. and a few limited details, number of attacks, which can help me when I'm trying to determine, well, what is chronic mania in 1918, or whenever this...
1898 first.
Yeah, 1898. Just as a side, chronic mania in these cases almost always means schizophrenia. And I'll get date of discharge, reason for discharge, in this case died, and if possible, the cause of death, in this case enterocolitis. Okay, that's a pretty complete record prior to 1920. Now, one liability that I have is that because I'm dealing with files coming from the infirmary, pretty much all of my patients stay at the asylum until they die. That's actually not representative of the entire population. From as near as I can tell from the superintendent's records, about a third to a half of patients admitted stayed until they died. And most of them, for reasons that we'll talk about in a few minutes, that really didn't have, that actually had more to do with their diagnosis than they had to do with anything about the conditions or the like at the asylum. But unfortunately, I don't get to see right now the patients who are discharged as recovered, improved, however they wanted to phrase it. That's why I want to ultimately get to the paper records, because those didn't come from the infirmary. Come on. Seems like I have to keep tapping. Oh, there we go. Now, this is a guy, I can't tell you my admiration for C.D. Mitchell. This guy was brought on as the superintendent of the asylum after a real scandal in 2000. Whoops. What happened? What did I just, oh, there we go. After a real scandal that happened, it's the classic scandal in any kind of institutional situation. The upper muckety-mucks of the asylum were skimming mostly supplies off of the asylum, you know, like taking their grocery bill from the asylum. Remember, the asylum was a fully functioning farm as well. But I posted this because I wanted you to see this. This is an excerpt from the biennial report of 1919 to 1921. So this is the first report that C.D. Mitchell had of his own. And he points out, on my appointment as superintendent, I found that there were practically no records being kept of the condition of the patients, a mere diagnosis being given to the case, and any of the problems arising in each individual case were never recorded. So that's all I got for a lot of these early cases is they were admitted. What happened to them? And to combat that, he was very aggressive. He hired a guy from Connecticut to come down here as his chief of staff, who, using the guidelines of the forerunner of the APA, you may think that the Diagnostic and Statistical Manual is recent. First manual appeared in 1918. Okay, and that manual included extensive information about how you should document case files. And the physician that they brought in from Connecticut proceeded to do that. So every patient came in, they were fully documented by a committee of 4 or 5 physicians. To the extent possible, their progress was followed. The extent possible is limited by, whoops, what the heck? Yeah, to the extent possible is limited by the fact that throughout Mitchell's term, population of the asylum, roughly 2,500 patients. Number of physicians, 7.
Wow.
7. So they considered it a win if they saw each patient once every couple of weeks or so, okay? Nursing staff was a bit better, but not much, okay? This was not for want of trying. Every one of the biennial reports begins with a plea: we are overtaxed. We need more people here. We cannot do properly by these patients. And he specifically mentions the African American patients who he knows are underserved. And of course, the state of Mississippi was just as eager in the 1920s to allocate money to the asylum as they are today to mental health care. So, my goal. First thing I want to do is compile a searchable database of patient demographics, anthropometrics, diagnoses, comorbidities, treatments, cause of death, where they were interred. These 2 things are particularly important for the bioarchaeologist. So, if a patient has a record of scoliosis, kyphosis, etc., that is a huge help for Jennifer and her crew. Because even though there won't be much left, often you can tell from what remains some of the major problems. The purpose is to identify patients for families and bioarchaeologists, and also for psychiatric and medical history. All right. So my initial questions: who went to the asylum? Who were they? Where did they come from? What sex were they? How old were they? What social race were they? Why were they committed to the asylum? What was their diagnosis? What was their physical health? What kind of socioeconomic factors were they living under? And what happened to them in the asylum? What treatments did they have? How long did they stay here? Why did they die? And what happened to their remains? So, first thing to know is that Mississippi State racial demographics changed over the life of the asylum. So prior to the 1900s, Mississippi was a majority state of African Americans and other people of color. At the time that I'm looking, the state's population is in transition. It's moving from a majority African American to 50-50, and then later with the Great Migration north, the population dynamic shift. Okay, now, another thing to bear in mind, my sample is skewed to patients admitted in the 1920s. Oops. Okay, so biggest population is here. Over the course of the population I'm looking at, the hospital census increased from roughly 1,800 in the early 20s to the 2,500s or so later. Admissions remained pretty stable, although people of color always were admitted more frequently than Caucasians. Mortality rate was appalling. The death rate of people of color was almost twice that of Caucasian patients. There were a lot of problems. There was crowding, bad ventilation, dilapidated structure, leading to 300 patients died who should not have died, who would have lived and been mentally restored could they have been on wards such as will be provided for them in the new hospital. Okay? So don't think that the staff of the asylum didn't care. They did, but they did not have resources. The superintendents, the state of Mississippi, knew that the asylum was falling apart as early as 1910, okay? The problem was World War I and economic crashes kept delaying the building of this place. Most of the patients came from the Delta or the Capital River region, and then they were roughly evenly distributed, the remainder among the western side, or eastern side of the state, I should say. Left-handed, I get these things confused pretty easily. Okay, men were admitted slightly more often than women. Patients of color were disproportionately admitted by about 2 to 1. Marital status, well, most patients were married or widowed on admission. Admissions, as you might imagine, peaked with patients between 20 and 40. It's something I want you to notice. At least a third of admissions were patients over 40. Now, if you encounter a patient over 40 who presents for the first time, what's one of the first things you're going to think of?
Syphilis.
Well, no, before syphilis. What mental situation are you going to think of?
Dementia.
Dementia, right. And as we're going to find out, in fact, a huge proportion of the patients, certainly that I've reviewed, fit the qualifications for one of the neurocognitive disorders. The patients had a range of occupations, but as you might imagine, most of them were farmers, or worked on farms, or worked near farms, or worked on things related to farms. I don't think that's changed all that much. Although my favorite entry of all, the little old lady, 60 years old, widow, occupation, bootlegger. My kind of woman. Best part about that was the interview. Ma'am, do you drink? I drink. How much do you drink? Oh, a jar or so. A day? Well, that's how it comes. Needless to say, she was a happy patient, but she didn't live terribly long. Okay. Most patients were pretty limited in education. Almost over a quarter had no education at all, and pretty much everybody was limited to some level of elementary school education. You have a handful of college-educated people, a few physicians, et cetera, but not many. And what a surprise. Religious affiliation, kind of skewed toward Baptists. Although my tribe is represented, there are several Hebrews. listed. I love that designation. The only thing better would be Red Sea pedestrian. Anyway, now, when the patients came in, psychosis was the major diagnosis. Now, why is that? Well, it's because at the time, almost anything more severe than what you would consider a common low-grade outpatient condition was classified as a psychosis of some sort. Now, they did make the distinction between dementia praecox, which we now know as schizophrenia. They also recognized bipolar disorder. They also recognized several neurocognitive disorders, general paralysis of the insane, and pellagra. Yeah. What I want you to see, though, is after I've applied DSM-5 TR criteria, almost half of the patients would qualify as a neurocognitive disorder, followed rapidly by schizophrenia and bipolar disorder. And then you start seeing disorders that you wouldn't normally see anymore. Epilepsy, intellectual development disorder. You don't see those so much in this institution. All right. So, two of the three most common causes of neurocognitive disorder are ones you aren't likely to see: syphilis and pellagra. Now, I will tell you right off the bat that that's partly why the mortality rate is so high. What's going on when somebody has neurocognitive impairment due to syphilis? They're dying. How about pellagra? What are the 4 Ds? Death. So when you get to dementia, death is really close behind that, okay? But they did also see a large number of patients that I think, to the best of my estimate, would qualify as vascular dementias. And I base that primarily on the fact that either they had a record of stroke or mini stroke, or they had remarkably high blood pressures, like 250 over 150. And remember, this was a time before antihypertensives. The best they could tell the patient is, don't get stressed. Yeah. Patients frequently had comorbid pellagra, hypertension or cardiovascular disease, and or syphilis, okay? So that's when I say, when you see the death rate at the asylum, recognize that people didn't enter the asylum in many cases until they were really close to death. I can't tell you how many cases I have with stays of 3 days, 5 days, 1 day, because they came in so physically sick, all the hospital could do is pronounce them dead and bury them. Also, something that I'm seeing a lot of is nosocomial acquisition of tuberculosis. Tuberculosis, not at all surprising given the crowded conditions and the inability to treat tuberculosis, but also pellagra. They were beginning, by the end of the period that I'm looking at, they were beginning to understand the causes of pellagra, but they still didn't have them well established. So there were lots of patients who weren't getting enough B vitamins and were in fact developing pellagra on campus. All right. Anybody have a solution? There we go. Psychiatric treatment options were pretty limited. One of the most common, hydrotherapy. I will say the patient, regardless of what happened to the patients, they were clean. They were very, very clean. They did use cold packs. Interestingly, the state asylum was the first school of occupational therapy in the state of Mississippi. Okay? They did have sedatives, anything from the old favorites of paraldehyde and apomorphine to the more recent phenobarb, bromides, and amibarbital. They did introduce metrazole-induced convulsive therapy. There are 1 or 2 cases that I suspect were insulin coma therapy, but they discarded that pretty quickly, not too surprisingly. And they introduced electroconvulsive therapy after 1938. What I want you to notice, though, they typically introduced every new therapy that came on the market within a year of its publication. They were keeping on top of things. And they were treating, by the way, they were treating epileptic patients with phenobarbital. They knew what they were doing. Nutritional, cardiovascular, and infectious disease, not too surprisingly, account for most of the deaths. One that's irritating as heck to me is death by maniacal exhaustion. Even in the 1930s, there is a publication from one doc at least saying, stop using this diagnosis, it doesn't mean anything. But they used it.
What was GPI?
Oh, general paralysis of the insane. Sorry. They did have some therapies available. For syphilis, they had mercurials and arsenicals. They used malaria therapy and diathermy, which are pretty similar. For pellagra, they did understand they needed to improve diet. They added brewer's yeast, thiamine, B12 folic acid, B-complex, but you can see it took time to develop these. For tuberculosis, same as everywhere else, isolation, rest, fresh air, supportive therapy. They had essentially nothing for chronic cardiovascular disease or chronic kidney disease. And until the 1910s, they didn't have any treatment for epilepsy, but then they began using phenobarbital. One thing that confused me initially was that I kept seeing patients referred to as suffering from some form of epileptic mania, epileptic dementia, etc. And at first, when I first was looking at the files, I kind of wrote it off as, oh, it was just the ignorance of the era. And then I got to realizing, Dr. Norton, what happens to the brain of a person who has epilepsy that is never controlled and they suffer from grand mal seizures?
Degeneration.
It degenerates. And that's what they were seeing. That's what they were talking about.
Wow.
As I say, you run into diagnoses you just don't see today. Thank goodness. Now, most patients stayed less than 3 years, but a large number stayed much longer. So about a third or so stayed over 3 years, some as many as 40, okay? Most of the people who died at the state hospital were interred there. Now, this is interesting. You know, a lot of people assume that when patients were, at this time, when patients were admitted to the asylum because of social prejudice, yada, 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 that the families disowned them, ignored them. No. Most patients, that's not the case. There's typically extensive correspondence asking for the updates on their loved ones. And to their credit, the superintendent and his assistants answered every one of them, you know. They might have only answered it in a line or two, but they answered them. So then the question is, well, why were they buried at the hospital? And we'll talk about that in just a moment. So, summary of the data so far. Most patients came from the western side of Mississippi. Whoop. What did I just do? There we go. New. Oh, this is fun. I always like doing this.
Thank you.
Well, I just wanted to review this for you all, you know, just in case you missed anything. Okay, summary so far. Okay, most patients came from western part of Mississippi. Men and women were equally likely to be admitted. People of color were disproportionately likely to be admitted. Most of the patients were rural, poor, and had limited education, but they were comparable to the state demographics. Neurocognitive disorders were responsible for an unexpectedly large number of admissions. I really wasn't expecting that. Most patients had serious comorbid somatic disorders. These comorbidities contributed to a large proportion of patient deaths. Many patients lived at the asylum until they died. And of course, this being files drawn from the infirmary, that's pretty much all of my files. Most patients who died at the asylum were interred at the hospital cemetery, and many were returned home. So let's talk about some confounds. This is where the scientist here comes out, okay? What do we have to watch out for? Well, the first thing is these are files from the infirmary, okay? That means by default, all of these patients had some form of somatic disorder. They were the sickest patients on campus. They're reflective of patients with a significant comorbidity. Question is, were they sicker on arrival or sicker due to different standards of care, either before or after arrival? Were race and racism related to health risks? What was their access to health care? What were the community standards of care? What were the cultural views about the origins of disease or seeking treatment for disease? We know all of those factors influence whether people get treated today. Why shouldn't they affect it back then? Region of origin, was that related to health risks, disease prevalence, occupational hazards, or catastrophic events like the Mississippi flood? I do, in fact, have several cases that are referred to as flood refugees, okay? So it obviously played some role. So what are the future questions? Well, first, why were so many people of color admitted compared to whites? Was this due to racism, socioeconomic status, illness burden, community factors, attitudes, other factors? I mean, it's easy to jump to some ideas, but we just don't know. We don't have that information yet. Why did the asylum receive so many patients with neurocognitive disorders? Seems an unusual thing. Is this an artifact of the infirmary files, or is this due to lack of family or community resources? One thing to remember is they didn't even have the rudimentary system of extended care facilities that we have today, okay? So patients with neurocognitive disorders were cared for by their family and their community until they couldn't anymore. And that's what I see a lot of, patients whose community or family resources were just exhausted.
Did they have to go through the legal system to get us in?
Yep. Had to either be a formal court admission or 2 physicians and a civilian. Why did so many patients remain at the asylum until they died? Okay, now part of that's just because I'm looking at the infirmary cases, so yeah. Or was it something else, you know? Was it comorbidities on admission, nosocomial illness? In view of the extensive family correspondence, why were so few patients interred at home? Was it practical or hygiene concerns? Remember, the asylum had no morgue. It had no refrigerator. It had no embalming facilities, which meant that you can imagine in July or August in Mississippi, if somebody isn't interred quickly, it's not going to be pleasant. And I suspect that's behind a lot of them. But also the financial burden. Shipping a body home at that time would cost between $75 and $100, which in modern terms is somewhere in the ballpark of $5,000 plus dollars. Now you tell me how many Mississippi farmers today can afford to cough up $5,000 to ship somebody home, especially when there is a cemetery and they know from reputation their loved one will be respectfully buried. Communication difficulties, I see that all the time. People didn't have phones. You know, how do you get in touch with somebody who's out in the back of beyond with no phone? Or were there social customs involved? We don't know. So, once I get this in shape to process with statistical software, I want to know what's the different distribution of diagnosis by social, race, sex, education, decade? You know, is there some bias there? What's the relative frequency of schizophrenia, bipolar, and major depressive disorder? And is it similar to current diagnostic patterns?
We needed a review again.
Yes. Thank you so much. This is still better than the one I'm dealing with at the Med Center in the, okay. So, questions? Yes, sir.
Were there, in the records, were there any mentions of malpractice at all, or any documents
No,
like that? Like,
no, no. I don't think you'd see any. No, there weren't. Yeah.
What's the most striking thing you learned from these cases?
Most striking thing I've learned is the proportion of patients suffering from neurocognitive disorders that were admitted. This has been suspected for a while, but it was pretty strikingly confirmed. Now, again, remember the bias. It's the infirmary patients, so you'd expect more neurocognitive disorders there. Still, that's an awful lot of neurocognitive disorders.
More community burden, or just?
Yeah. I mean, they had no facilities. You know, you're talking about poor, remember where they're coming from. They're coming from the Delta. They're coming from the rural regions of the Capital River region. They don't have community, they don't have community services now. You know, they sure as heck didn't have them then. And what you see over and over in the records is patient X was treated by brother, sister, mother, father, until they couldn't, and then they were sent to the asylum. Okay, they weren't sent to the asylum just to get rid of them, they just couldn't take care of them anymore. We all know that a lot of patients with neurocognitive disorders reach a stage where it's not really feasible for one person to take care of them. There needs to be a team. Yes?
Fabulous.
Oh, thanks.
And secondly, I didn't see substance abuse mentioned.
There was, but it's kind of hard to pinpoint, and here's why. Mississippi was theoretically a dry state at that time, okay? Any alcohol use often was called alcoholism, even though in the interview or in the records, it's like had a couple of drinks a week. Doesn't really qualify. The ones that you do see, I've seen a handful of cases of morphine or other opiate abuse, which makes perfect sense. Especially in the early part of the 20th century, it was over the counter.
Did the doctors live on campus?
Mm-hmm. Yep, almost entirely. Any other questions?
So you mentioned a lot of the neurocognitive disorders where like syphilis, pellagra, there's something that was causing it
Oh, yeah.
identified. For the ones where they maybe didn't identify a cause as easily or wasn't reported as such, did you notice a trend in how they would treat the classical dementia patient? Were there trends in how they would
Unfortunately,
treat that?
yeah. In most cases, it was pretty much across the board supportive. Now, part of that may have to do with the time involved. Since I'm the only patients that I can follow beyond 1935 are the patients that were admitted before and stayed, that's not a big enough sample to make any conclusions about. Of the patients who remained on who I could follow all the way, it was pretty much all supportive. Again, their staff was terribly, terribly limited. I mean, it's shocking sometimes when you read the superintendent's reports, just how few people were available to treat.
Will you get access to after 1935 eventually?
I doubt it. Well, yes, eventually, but you start getting into the ethical issues as well as the legal issues. I can be pretty certain that very few, if any, people know personally the patients that I'm reviewing.
Right.
But as we move forward in time, that becomes harder and harder. Also, right now the mandate is the patients related to the asylum rather than to the state hospital system as a whole. What I'd really like to get access to are those paper files, because that will give me a sample of the more typical sample from the asylum that weren't in the infirmary or had been discharged from the infirmary.
Do you think there's still unmarked graves underneath the med center?
Good possibility.
Yeah.
I mean, given the survey that's been done, it does look, if you're familiar with the medical center layout, it does look as though they're all east of East University Drive, so where the old laundry facility was. Now, there's constant speculation about what's under the VA parking lot. I mean, I'm not kidding. I mean, but there's no way really to know. And strangely enough, the VA hasn't jumped forward and said, yes, please excavate our parking lot. But I would say we've got a pretty fair tab on them. Yeah, but yeah, anything's possible.
That's fabulous. Thank you.
Yes.
You mentioned that one of the goals of the project was to identify the remains of some individuals that are buried near this. And I was curious, like, what are the methods that are being used to,
Oh, yeah, okay.
and how successful
Well,
that?
you know, obviously there are things like coffin hardware is used because that survives. The wood generally doesn't survive so well, but the hardware does. Any any jewelry or, for example, dentures or the like that are found. And then with my records, it's okay. What's the height of the patient? What's the sex of the patient? Are they missing any limbs or digits, which at the time was relatively common? What's their dentition like? Okay. Again, that's somewhat, I haven't talked about the dentition, but let's just say be very glad for modern dentistry. Be very, very glad. Let's put it this way. At this point, pretty much all of you would be missing at least a third of your teeth. But that's the kind of anthropomorphic data or that I try to capture from the files. And then, placement in the cemetery plays some importance because there is an order to it. So it's not like they randomly interred patients. If you go back to that map that I showed early on, you'll see that the graves are in rows. Okay, and they appear to be in rows from oldest in the north to newest in the south. And that includes a certain number of patients who are still buried there after the move to Whitfield.
Who buried them all? Just
They had a couple of, they had apparently several ministers on rotation. The Catholic Church was very diligent about sending a priest over. The Jewish congregation, Beth Israel, there are no, as far as I can tell, there are no Jews buried in that cemetery. They were immediately taken by Beth Israel. But there was generally kind of a rotating Protestant minister pool. So there was always some clergy involved. And then there are a couple of names that come up over and over again who appear to have been, for want of a better term, the cemetery superintendent. One thing I'll tell you that I've discovered, Wright and Ferguson is really old. They were still responsible for a large number of burials. Also, by the way, something I didn't talk about 30 patients were shipped to the University Medical School. And there, I can pretty much guarantee racism comes into play because of the 30, 29 were people of color. So, I mean, I don't think there's any real question there. Which, given attitudes at the time is completely cognitive dissonance. If you're telling each other that African Americans are completely different from white people, then why are the med students only dissecting the African Americans? That's stupid. But that's the times.
was that superintendent in his his time recognized for all he did?
Yes, he was. Yes, he was. And he was superintendent for a long time. I mean, through the Second World War. Yeah, he was. He was also recognized because prior to him, particularly between the Civil War and 1920, when Mitchell came in, the asylum appears to have had a string of superintendents who can charitably be described as ne'er-do-wells. You know, they were basically mining the asylum for, its farm produce.
Is there an easy way to keep up with like your progress and then the progress of the project as a whole?
Yeah, there is an Asylum Hill website. My progress is not yet out there, but I'm working to figure out how to put it out there. But yeah, and you can always invite me back, and I'll be happy to give you an update.
Thanks for doing this. You could have just faded into...
Oh, no way. This is way too interesting. This is way too interesting. But thank you all. And by the way, for those of you that, like me, always think of questions 10 minutes after the speaker leaves, ipaul@umc.edu. If you don't remember that, ask Dr. Norton. He knows.
Thank you so much.
My pleasure.
Yeah, that was awesome.
Thank you, sir.
I'm sitting there thinking that's the best pronouns I've heard. Really.
Oh, thank you.
I'll say hi to Luke for you, too.
Yes, I was about to ask you about
He's in
him.
Charlotte. He's big in IT.
Into what?
IT.
Oh,